This is the FlightBridgeED Podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Hey folks, Eric back with you. Today we're going to jump into a podcast. Should be about 15 or 20 minutes. We're going to continue with our vasopressor podcast and jump in and actually look at the specific vasopressors. If you remember, we did the first podcast and we looked at inopressors, and those inopressors were specifically dopamine and levophed. And now we're going to look at neo-synephrine, we're going to look at vasopressin, and we're going to look at a new medication that you don't hear a lot about. There's been a lot of studies called methylene blue, and we know methylene blue is a medication that we teach on as far as in critical care for an antidote for potassium cyanide poisoning. And so we're going to discuss that. I've got some studies I'll post in the show notes, and we'll discuss that. Before we jump in, I just want to say thank you. I know the Critical Care Transport Conference just ended yesterday in North Carolina. I saw a lot of great tweets from followers of FlightBridgeED. I know Mike Abernathy did a lecture on FOAMed and talked about our podcast, so I want to thank him. That was very nice. So, really cool. I apologize for not being there. This week was just really crazy. I'm leaving tomorrow for a review class in Portland, Oregon, and I had to work 2 shifts and get everything ready to go. So I'm recording this podcast at about 11 o'clock at night and try to get this done, and I've got to catch a flight in the morning at 4. So we're going to jump into this podcast, and like I said, it should be about 15 to 20 minutes. Also, before we start, I just want to also say I really, really appreciate all the kind words I hear from people on Twitter, on LinkedIn, the emails I get, and the following we have. We've truly superseded anything that I could have ever imagined, and we're reaching the 500,000 download range. We've got listeners now in almost 40 countries, I think 38 or 39. So that's pretty amazing to me that we're getting such a response. One of the things that we have to remember, though, is the content that we put out, the content that I put out, it's all study-based. It's all mainstream critical care medicine. I'm not teaching anything that's not in the studies, but we also have to understand that I have a primary job, you have a primary job, and your primary job, your primary medical directors, the company you work for, they may see things differently. There's a lot of factors that go into setting a protocol and going off a protocol, and change doesn't happen overnight. Just because there may be some studies out that are showing benefits in a medication or an approach to a procedure, that doesn't mean that your company that you work for is going to adopt that right now. They may never adopt that. I hear that people are challenging clinical issues and basically referring to me as, well, this is what FlightBridgeED teaches. Why aren't we doing that? Take what you learn from FlightBridgeED, apply it to your practice based on your protocols. If it's not something in your protocols, that doesn't mean that this gives you permission to do so. And I just wanted to put this out here. I'm so thankful for all the listeners, so thankful for all the kind words, but we also have to realize that we each have jobs, and we each have medical directors that may see things differently. And I know if you've been doing this for very long, you know what I'm talking about. You get 5 doctors in a room, and you may get 5 different answers on one presentation or a medication that they like to use, and that's why they're doctors. They can do that. Again, that doesn't mean that we can't attempt to change the culture. Doesn't mean that I can't present things to the right people, but things don't happen overnight. With that being said, we'll jump into the podcast. Again, thank you so much for following us and listening, but I just needed to kind of put that out there. So let's jump in. We're going to start off with vasopressors, pure vasopressors. And again, neo-synephrine, vasopressin, methylene blue. When we look at neo-synephrine is a medication that we oftentimes looked at, and this was a second-line medication as far as a pure vasopressor. And, you used levophed. We discussed that levophed is now primarily in mainstream critical care, your primary first-line inopressor. It's got excellent preload and afterload effects. And if you haven't listened to that podcast, it's a podcast called Get Rid of Dopamine and in EMS, add levophed. But the thing with neo-synephrine and, some of the things that these other top critical care intensivists around the world are seeing with neo-synephrine is there's some negative effects that I really didn't think about. Because neo-synephrine has got such potent alpha 1 and alpha 2 stimulation, you have an excellent ability to improve blood pressure. You have good ability to actually improve pressure in that aortic root. Coronary artery perfusion pressure improves, but it's such a potent vasopressor that you get so much squeeze, and we have to understand that if we squeeze down too hard and we don't have good cardiac output, so if we haven't fixed the cardiac output, if we haven't added enough volume and you squeeze down too hard, are you truly helping the patient? And I would argue you're not. You're actually squeezing down so hard that are you allowing or optimizing blood flow? We have to have blood flow. We have to have blood flow. We have to have oxygen-rich hemoglobin being circulated. Remember, we've talked a lot about that in that hyperdynamic state, especially in sepsis, a lot of times we're not meeting the demand, right? Our delivery is so much, but that demand is far exceeding that delivery. So we have to be able to circulate that oxygen-rich hemoglobin so our body can utilize that. If you're squeezing down so hard with neo-synephrine, then there's no real ability to do that. And then from outward looking in, and you look at that blood pressure and you're like, wow, I've got a great blood pressure, and that's going to give you that false sense. So we have to remember that neo-synephrine is something that may be second or third line, and it's really losing favor in a lot of critical care realms around the country. So remember, you have a loading dose. Your loading dose is 10 to 100 mics, and then you jump in and you do a maintenance of 40 to 60 mics a minute. The big thing with that's good about neo-synephrine is if you had a patient that you didn't want to increase heart rate, but you wanted some squeeze, neo-synephrine would be a great medication there. You're not going to have any tachycardia, right? And we see this oftentimes with dopamine, where you have the associated tachycardia. You've got that huge chronotropic effect that kind of overtakes the medication, especially when you increase above 10 mics per kilo per minute. We discussed that in the last podcast. So when we look at neo-synephrine, primarily the way I was taught that neo-synephrine was used for those really, really poor patients with neurogenic shocks, right? So massive container failures where you needed that squeeze. And there still may be benefit in that. But again, hearing how other intensivists are talking, they would still go with Levophed as their first line medication in that setting. So, just take that and think about it. And the other negative thing about neo-synephrine that we have to think about is how do we look at perfusion? Well, perfusion is looked at in our patients that are sick like this. And any patients that we fly or transport is based on their urine output. And I discussed that extensively with dopamine, how it gives you that false perfusion, or I should say that false urine output. And it gives the clinician the feeling that their patient is perfusing better than they truly are. Well, that's the same issue with neo-synephrine, but just in reverse. It actually decreases perfusion to the kidneys, and it can actually cause kidney necrosis in that way. So we have to think about, again, for those of you that are paramedics and you're listening and you're attempting to get into the critical care realm or the flight realm, or nurses, you know what I'm talking about. We have to be thinking long term. We can't be thinking acutely on these patients. We have to think about what we do now could affect them negatively 2, 3, 4 days from now. And so all those things need to be a big factor. And that's why I'm a big component on you need to know your pharmacology. Pharmacology should be a big deal to you. You should always be reviewing, always be learning it. It should be in rote memory. All this should be memorized because it's that important. So that's all I have as far as neo-synephrine. Again, there may be some advantages, maybe in a severe neurogenic shock, but I would always go Levophed first. If that's not working, you could go with a small dose of neo-synephrine. But again, you need to look at the patient, look at their kidneys, look at their renal. Are they in acute renal failure? Are they chronic renal failure? and then make a decision based on that. And we're going to talk about a couple other medications here that may be a benefit in those situations. The next medication, which is pretty cool, is vasopressin. So vasopressin is something that we used that came along about, it's probably been 10 years now, and it was added to the ACLS guidelines, and we gave a 40-unit dose instead of your epinephrine. And vasopressin has been used in the ICU for a long time, and it's used for two different things. It's used for patients with GI bleeds that are also hypovolemic and they're in shock or vasodilatory shock, and it's also used for sepsis. So we have to look at vasopressin, and we have to look at this and not get scared of it. And I think talking to people, they're a little scared of it. We're going to hang a vasopressin drip. Well, if you talk to these nurses that have worked these units, they've hung lots of vasopressin drips, and I haven't heard anything negative about vasopressin. If you listen to some of these intensivists teach, same thing. Vasopressin is an excellent medication. So excellent for patients that have a profound vasodilatory shock, so septic shock, and they're not responding to the Levophed. One of the things that we have to understand with patients that are in shock, in septic shock, I should say, is they're adrenal insufficient. And that's why most patients in sepsis get hydrocortisone, because of the adrenal insufficiency, and the stress hormone cortisol is not being released. So we need to try to stimulate that adrenal gland, and that's why we give these hydrocortisone. Well, we also have a vasopressin depletion based on the same process. So their vasopressin receptors are depleted, and you need that. You need the vasopressin. So vasopressin is going to be excellent in that way. You're going to load that up. If the patient doesn't have any vasopressin depletion, they don't need it, this medication is very, very safe. It's not going to cause any harm if you hang it and the patient doesn't need it. In that realm, it's not going to hurt the patient. The cool thing about this is it's effective in 85% of the patients where they have refractory hypotension secondary to Levophed. So you've given your Levophed, and after giving a full dose of Levophed, right, you've maxed out that dose, they're still refractory as far as hypotensive. So why is that? Well, another issue that comes up is patients have only so many neurotransmitters, and you start using these medications like norepinephrine and other vasopressors, and your neurotransmitters get used up. And so vasopressin actually releases those neurotransmitters and allows for more uptake for purposes of utilizing this medication for vasoconstriction. So vasopressin is great in those realms. It's going to restore the vasopressin that's depleted because of the adrenal insufficiency. It's also going to release those neurotransmitters and allow for more uptake of the other vasopressors that are on board. Specifically, we're talking about norepinephrine. And it's got very potent vasoconstrictive effects. So it really does a lot. The dose range is real easy. It's 0.01 to 0.04 units a minute. What I've seen and read, a lot of times they just go 0.04 units a minute. As far as mixing it, I've played around with two different ways. The one I found is easiest. A lot of times we only carry 20 unit vials. It's just put 20 units in 100 mils. Put it into your pump at 0.04 units a minute and go to town. And again, very narrow therapeutic range. If it doesn't work, you're not going to have any ill effects. But from what I've been told and seeing this in use, very, very positive effects using this as a second-line vasopressor. So for me, and our protocols, we have the option. We can go Levophed, number 1, and I go vasopressin, number 2. I just was talking to a colleague, Tony Harrison, the other day, and he believes, and based on his ICU experience, he prefers going vasopressin first and Levophed second. Again, if you have that option, if you have that availability in your protocol, then, do that. Again, that's going to be based on your protocol and your protocol only. And then the last medication is something called methylene blue, and I talked about this a little bit in the beginning that we teach this in critical care as an antidote to potassium cyanide poisoning. And this is actually a test question on the FPC and the CFRN exams. They'll specifically ask about potassium cyanide poisoning, and methylene blue is the antidote for that. But as early as 1992, they started looking at studies with methylene blue, and they started looking at its potential effects in septic shock. And they've had amazing effects with methylene blue. It works really similar to how vasopressin releases those neurotransmitters. And then the other big thing that you see with this is the inflammatory response that triggers oftentimes sepsis and ARDS. When we have an inflammatory response, that inflammatory response starts attacking all those epithelials, right? It starts causing breakdown of the cytokines. We start having a glycocalyx. The glycocalyx are those finger-like projections off of the vessel, those capillaries that holds that osmotic pressure together. So imagine that's what causes that hose, a soaker hose kind of effect where you start having that capillary leakage. Well, we also have nitric oxide, and our nitric oxide is something that is a potent vasodilator. Because of that, it actually starts breaking down and it starts releasing more nitric oxide. That's where we get more of that capillary leakage because we have more vasodilation. Well, methylene blue is a very potent nitric oxide inhibitor. So it actually reduces the incidence of the nitric oxide releasing and causing vasodilation in the lungs and the capillaries. So when we look at this, it inhibits the nitric oxide. The nitric oxide is causing more capillary leakage. It's causing a bigger issue, and we don't want all that third spacing. That's the whole point of thinking about using less fluid on these septic patients, using early levofed that optimizes that preload, manage that CVP, keep that CVP in that 8 to 12 range, low amount of fluid, maybe lift the legs, bring that dependent fluid that's in the legs into the core, maybe limit your fluids at 2 liters, start that levofed, and maybe consider vasopressin early or consider methylene blue if you had that option. Again, this is a new concept as far as pre-hospital critical care. I don't know of any protocols right now that has this, but when I came across this study, I was blown away by it. Everything I've read has been very, very positive. The dosing is 1.5 to 2 milligrams per kilogram. That's a loading dose over 20 minutes. It's also a very effective in decreasing the need for other vasopressors. So it will actually lower or allow you to lower the dosing in the other vasopressors. One of the studies that I'll post in the show notes is titled The Use of Continuous Methylene Blue for the Treatment of Refractory Septic Shock, a New Standard. They had a 64-year-old female with significant past history of toxic colitis. On admission, she was hemodynamically stable. However, later she developed progressive lactic acidosis. She then was diagnosed with a small bowel obstruction, and she had exploratory surgery. So after admission to the ICU, she became progressively hypotensive, and her MAP pressures started dropping below 60. She had lactate levels that were exceedingly high. I think they were at 6 or 7. During that time, multiple boluses of crystalloids were given in an effort to obviously alleviate that hypotension, and they started looking at her hemodynamic numbers. She had a very low SVR. She had a very high cardiac output, and her CVP was approximately 20. So what they did was, so that's a really high CVP, and there's other reasons why that may be high. We're not going to get into that. But what they did is they had her maxed out on levofed, and they decided to try methylene blue. And they gave a loading dose, actually lower than what I stated. They gave a loading dose of 1 milligram per kilogram. They gave it over 20 minutes. And after they did that, they dropped the dose down to 0.5 milligrams per kilogram over 8 hours. The immediate effect of the infusion was rapid restoration of the hemodynamic stability and subsequent decrease in vasopressor requirements. Unlike what it has been reported before, the author was able to discontinue the methylene blue infusion without further need for vasopressors. So essentially, they had a patient that was hemodynamically unstable and heading for that hemodynamic collapse. They had levofed that was maxed out. They tried methylene blue at the dosing range that I stated. And after giving the methylene blue over the 20 minutes and then giving the 0.5 milligrams per kilogram an hour over 8 hours, they were able to basically remove all the other vasopressors, stop the methylene blue infusion. The patient was ultimately discharged a few days later and had no problems secondary to that and lived a normal life. Obviously, this is one paper, and I'll try to find multiple papers regarding this. But from what I'm reading and what I'm seeing, and what I've heard, even Scott Weingart from MCRIT has talked a little about methylene blue, and he's starting to see favor in using this as well. Pretty cool stuff. I think for me, when I look at the whole inflammatory cascade and how that's such a big player in all these disease processes, whether we look at ARDS, sepsis, we look at DIC, that's a big culprit. And obviously nitric oxide is something that we give in certain patients, maybe patients that have pulmonary vascular resistance that are high. We talked a little bit about nitric oxide use when we have a pulmonary embolism because of that issue. So I think methylene blue is something that we can look at. This is something that definitely is going to see a lot more research on. We're going to probably see this more in mainstream critical care. And eventually you may see this kind of move towards pre-hospital critical care. I don't know. There may not be really a need when you look at our flight times, our transport times. Are you going to get to this medication? I don't know. So again, a lot of different studies out there regarding this, and I thought it was pretty cool. That's all I have for this podcast. Again, I want to thank everybody so much for the following. Again, I'm humbled every time that we see the numbers or we get tweets from Australia or Scotland or wherever. I'm just blown away by it, and I have to thank everybody. We're just going to keep trying to put out good content. Don't stop emailing me if you have good cases, you have questions. That's what I'm here for. I'll try to give you the best answer I can. If I don't have the answer, I'll find the answer or I'll steer you in the right direction. If you haven't looked on our website, we've got multiple review classes if that's something you're looking to do. If you currently have your FPC or CFRN, go on there, see if there's a location that's close to you. And I do give a discounted rate for people that already have their FPC and CFRN because obviously you're not needing all the same materials. But share the podcast with people. Again, this is a free resource, and I think there's a great benefit to listening to a lot of this stuff over and over and over. And check out the YouTube channel if you haven't. We're up to 230 subscribers, and so that's pretty cool. So again, I just want to say thank you, and I will talk to you in about a week, and hope everybody has a great spring.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.